Thank you. Okay, so yeah, should be talking a particular intervention that is actually quite widespread within Malaysia. A lot of us actually use it on top of our day-to-day clinical ACT practices, mainly because it has been useful. It has allowed us a certain framework to be able to train people to be able to tap into psychological interventions. And Wendy herself, she is actually a well-established psychiatrist, internationally renowned. She's currently based in the UK, but prior to this, she actually worked for a rather long time within the Malaysia context. She's also our co-chair of our Developing Nations Committee, and she used to be the associate professor of University of Malaysia Sabah. She has a PhD in healthcare policy, and she has been practicing and teaching ACT for many, many years. We will go as far to say that about half of the ACT practitioners within Malaysia were all inspired or trained by her at one point or another. But anyway, without further ado, Wendy, I just hand over everything to you, and the floor is all yours. You need to unmute, Wendy.
You can tell I'm not teaching anymore because I forget that. So thank you very much for your introduction. People ask me why I was in Malaysia for so many years. I'm actually married to a Malaysian. So I went there in 2007 and I came back about a year ago. I'm training in child and adolescent psychiatry now. So I am going to talk today a bit about task sharing and how to get these interventions to as many people as possible. So I'm going to talk about training up non-specialist healthcare providers. So let me start my slides. Again, it's been a while since I've been doing this. Oh, nope. Right. Okay, that's worked. Can you see the slide there? You can see that, or is, oh no, I'm not sharing. Let's try again.
No.
Okay, is that working? Yes, I'm screen sharing.
Yes, yes, now.
Okay, excellent. Okay, so now to work out. All right, okay. I'm just trying to work out how it does it with Zoom. So yeah, this is the title of my talk: training up non-specialist healthcare providers in to deliver interventions. Right, let me go back. Okay, in ACT-based interventions. So as Eugene says, this is a project which it actually started about 10 years ago. It kind of came on from my PhD, which was in collaborative practice. And I'll go into a bit how I got involved in ACT and how this became part of it. So what I'm going to cover today, I'm going to talk about how we can provide psychological interventions in low resource settings. So I'm going to give a bit of an overview. I'm going to start with the general, then go into the specific, and then go out again to the general. So it won't just be about this project. I'm using this as a kind of an example of a way of doing things. So I'm going to talk about that. I'm going to talk about using non-specialist providers in general. It's what we call task sharing. Okay, and then I'm going to talk about the ultra brief intervention course and how we evaluate it. We've started to evaluate it as well, and what the future is. Okay, right, so just telling you about the setting. This is Sabah, which I think a lot of people have talked about today, because as you can see, we've got quite an active ACT community in Sabah. A lot of people are doing this now because it's quite useful in this context. So Sabah is here, part of the island of Borneo. It's about 1,000 kilometers from Kuala Lumpur. And one of the things that means is it's not that well resourced compared to this side of Malaysia. Compared to the Peninsula Malaysia, it's not so well resourced. It's often quite hard to get professionals to go there because it's far away. But I think that's changing now. So this is a close-up. So Sabah, it's well known for wildlife, scenery. Okay, I used to work in a place called University Malaysia Sabah, based in Kota Kinabalu. Okay, you can, from the people who've spoken today, you can probably see it's quite strong in things like public health, which has been quite a big influence in what we've developed. I always think about public health approaches and getting things to the maximum amount of people, rather than just delivering a really good intervention to a very small number of people. So that's where we're based. I also used to work in the State Psychiatric Hospital. That's a 300-bedded hospital based here in Kota Kinabalu. Okay, and like many countries, most of the resources for mental health is based on in the inpatient services. So that's where most of the staff are. And it kind of means that often a lot of other areas are neglected. So when I first arrived in Sabah, we had 3 psychiatrists covering the whole state. This is about the size of Scotland, and roughly the population of just under the population of Scotland. So it's quite big. It's got about 3 to 4 million people, and there was 3 psychiatrists covering it. That's now increased to 22 psychiatrists, but it's still not many for the size of the area. And now there's psychiatrists in a few other places. When you look at other professionals, it's really very few. So when I first arrived, there was no clinical psychologists in the state healthcare system in here. There's now one. So one clinical psychologist for that huge number of people. So it's way under-resourced. Okay, and just comparing that worldwide. Okay, this is from the World Health Organization Atlas. Actually, it has been updated now, but it's still not many people not many resources in lower middle and upper middle income countries. So this graph, it shows the number of psychiatrists, number of psychiatric nurses, because that's normally what they measure. If we looked at clinical psychologists, we'd see a much lower line. Okay, and this is where we are quite recently in Sabah. Okay, it's still quite a lot lower than the average upper middle income country. So it is quite a low resource environment. Okay. So this is the problem we are trying to solve. And I think it's the same problem that a lot of lower and middle income countries have. Actually, it's the same problem that higher income countries have, that most people don't get any form of psychological intervention. We know it works. We've got good evidence that it works for most conditions, but most people don't get it. And that's particularly the case if you have a lower educational level, if you're in a lower socioeconomic group, if you're rural, and if you have a psychotic illness. So if you're well off, you speak English, you're well educated, and you're in a city, and you've got a depressive type of illness, you might get some psychological therapy, okay, particularly if you can pay for it privately. But majority of people, there's no chance, okay, even though we know it works. And I like your presentation earlier, Merve, on the psychotic illnesses, because it really matters in this context, because that's the majority of the patients you see, or a huge proportion of the patients you see have psychotic illnesses. So it really matters in this context. Okay, so why do we have this problem? A lot of it's we don't have enough trained professionals, as I've shown you earlier. In public healthcare settings, the emphasis is on doctors and nurses, and that's political. They want to get those posts filled for doctors and nurses. So there's huge training programs for doctors and nurses. In fact, in Malaysia, they've even overproduced for these categories of staff. But when you look at allied health staff, any kind of therapist, occupational therapist, speech and language therapist, psychotherapist, there's no posts, there's hardly anyone trained. So it's not emphasized. And I think, as I say, it's partly political. They want to sort of sort out things like malaria and the communicable diseases particularly first. So I think that's why it is. There's a lack of political will to solve the problem. Although I think that is starting to change. Okay, the next one, the delivery models not being realistic. So often there's an emphasis on people like clinical psychologists delivering therapy. In Sabah, about I think it was about 7-8 years ago, we had a counsellor for a while working in the hospital, and she was doing really good work, working with clients individually, running some groups. Then the people in KL said that counsellors can't do therapy with people who have illnesses, which didn't make any sense to me, but that's what they said. So they withdrew the counsellor, and there was nobody to put back in the place. And it didn't make any sense at all, particularly in the context where we were. They had a few more resources in Kuala Lumpur. We didn't. It just made no sense. I don't think it makes sense there either. So the delivery models were not very realistic because there's nowhere near enough clinical psychologists. Okay, then large treatment gap. So most people with mental illnesses, they're not recognised as needing help or given evidence-based treatment. So, like, even if you get in the system, you're unlikely to get psychological therapy. But most people don't even get in the system in the first place. So one of the reasons why we see a lot more psychotic illness than other things is because the people with anxiety and depression just don't present in the first place. Okay, so that's common in lower middle income countries. Just going into this graph here. This is a study by Robert Cohn. This is, again, a few years old, but it's showing the treatment gap. Okay, this is worldwide. I think this is mainly lower middle income countries, but you can see it's quite high. Okay, in Sabah, my colleague actually measured it in Sabah. It's over 90%. The treatment gap for common mental disorders, things like anxiety and depression and alcohol use disorder. So it's really high. Okay, just going back to the reasons for that. Okay, often people don't want labels. And they're not aware of them in the first place. And one of the good things about ACT is we don't have to do that. We don't have to give people labels. So that's a big advantage. The trouble is they often don't end up in the system in the first place if they don't have that. Okay, we've got really overwhelmed health services. So your average primary care physician, they'll be seeing maybe 50 people in a morning. And it's quite hard to find out if somebody's got a mental illness or they're struggling with thoughts and feelings if you've only got 5 minutes a patient. Really, really tough. Okay, and then we've got alternative explanatory models. So we've got spiritual models. A lot of people will go first of all to their ustaz, their priest, their pastor, or to a alternative healer, because that's where traditionally people have got help. And we've done some studies with these people. We've done some qualitative studies with them. And actually, people are getting psychological interventions from those. So they're getting psychological interventions from religious professionals. Okay, they're often religious-based, but often they're quite effective. They do work. But it sometimes means that people with things like psychosis, they'll present really late because they've gone through all of that first. Okay. Some of them, though, some of the alternative healers, they will refer to us. So it doesn't always mean that people present late. In fact, one study showed that it doesn't really delay things at all. Okay, but it's one of the reasons why people don't end up, for example, in the healthcare system. Whether that's good or bad, I'm not sure. Okay. Oops, my slides are going around in loops. Okay, so now moving on to the solutions. Right, so the first thing we could do, I think one of the presenters in the paper presenters, they mentioned we can train more people, okay, which is the obvious thing to do. We can train up more clinical psychologists, more psychotherapists. Okay, that would be really great. Now, there are problems with that. Okay. So the main issue is it's just really difficult to do. So in higher income countries, we have around 30 to 100 clinical psychologists working in the mental health sector. Okay, so that's your average per head of population. Okay, so for Malaysia to get that many, need around 10 to 30,000 to be comparable. And currently, actually, this is about 2 years old or 3 years old. There's about 300 to 400, and the training lesson 100 a year. So as I said earlier, it's quite hard if you've not got much capacity in the first place to develop capacity, because you need those people to be trainers. And we went through a time a while ago. We were trying to develop a clinical psychology course, but it was really hard because we can't get enough people into training in the first place. And we tried to do the same also with psychiatric nurses. We tried to develop a post-basic course for psychiatric nursing, where we're actually training people to deliver therapies. And it was also really difficult because we have to get the staff to do that in the first place. Okay, so at this rate, it's going to take around 100 years to train 10,000 clinical psychologists. And in the meantime, we're not offering the majority of people any treatment. So it's a good idea, but it's really hard to do. Okay, the next thing, we could collaborate with traditional systems of care. And as I've said, those systems, in some ways, they work quite well, and people are used to using them. And sometimes they get quite good results. However, sometimes they don't, and people will continue to have symptoms, and they do need another system of care as well. I also find that some people don't want to use those systems of care because maybe they've had a bad experience with them. So they want to come to other systems as well. So one of my colleagues in the State Psychiatric Hospital, he was doing this. He developed a program where he's collaborating with people called Bobahizan, and they were trying to make sure that people are referred at the appropriate time and that kind of thing. Okay, so that's with traditional healers. Okay, next thing we can do, we can train up healthcare staff to deliver therapy. Okay, again, sounds like a really good idea. The problem is those people you're training are also really overwhelmed. So if you try and people who have tried to, I think quite a few people here will have tried to develop things, for example, in primary care. Okay, and you go to primary care and say, hey, do you want to take part in this new program? And they're like, what? We've got to do all these other programs. We've got to do diabetes. We've got to do the communicable diseases. We've got a malaria program. How are we going to do this other program? Are you kidding me? They're like, there's no way in the world that they want to do another program if it's going to take away from the time they've got already. Okay, so you're trying to tell people you're going to spend an hour doing therapy with people once a week. There's no chance. Okay, because everybody is overwhelmed in the system. So it's a nice idea, but very difficult to deliver. It has worked to some degree in terms of training mental health staff. So you can probably tell in Sabah, we've trained up quite a number of people in ACT, and like the medical officers in the university are doing that. A lot of psychiatrists are doing that. So that works. So we are doing that to some degree. Okay. Right, next one, we can train lay people to deliver therapy. Okay, and this is a really promising approach. So you've seen it already in the forum about Self-Help Plus. Okay, that Claudette Foley and her team are developing or have developed, and that's got some really promising results that we can see big changes in randomized control trials when we train up lay people. I'm just going to go over to this a bit more. Okay, so this is a video. My son made it, so I'm kind of really proud of it. It's very short, but it's just showing one way we're using this approach.
Kita sekarang ada di Kampung Kibogo, satu tempat yang sangat cantik seperti apa yang kamu nampak di sini. Apa yang kita buat hari ini di sini adalah satu projek yang sangat penting untuk Sabah. Apa yang kita buat di sini ialah kita sedang melatih satu kumpulan volunteer, satu kumpulan sukarelawan yang ditemakan sebagai peer support expert, yaitu pakar sokongan rakan sebaya untuk membantu orang-orang yang bermasalah dengan minuman alkohol.
Okay, I don't know if you could hear the sound there. I just realized that I probably didn't connect the sound, but I think you probably saw the text. So that's an example of task sharing. That was a program we developed for alcohol use disorders, and we trained up community members we trained them in a mixture of ACT skills and motivational interviewing. Okay, so it's an example of task sharing. I've just put another couple of slides and I can tell you how it relates to things going on elsewhere in the world. Okay, so task shifting is where you train non-specialists to deliver therapy. Okay, and in this case, it's lay people, right? So this guy, Singler, he's done a meta-analysis. Okay, overall, a reasonable effect size around 0.5. So that's a moderate effect size. It's not too different to most medications and CBT, for example. Okay, although effect sizes in lower middle income settings tend to be bigger because of often the treatment as usual isn't there so much. Okay, but that's a reasonable effect size. Okay, it's lay providers in communities. Normally what happens, you train a group of people The average time is about 2 weeks that you train them for. And you tend to use a manualized treatment. So you give them a manual about a particular way of delivering therapy for a particular condition. Okay, the mean duration of therapy of the sessions are about an hour, and the mean duration is around 10 weeks. It's mainly women targeted in a lot of these trials, and I think the reason behind that is many of the lay providers are women as well. Okay, and it's often for common mental disorders, right? The reason I've got a bench here is because one of the most successful of these schemes is something called the Friendship Bench Scheme in Zimbabwe, where it's normally an older woman who delivers therapy sitting on a bench in the community, and people just go and sit next to her and talk about their problems. Okay, so the one I just showed as an example, it's kind of like this, but we didn't give anything like this amount of training. We just delivered 6 sessions over about 6 weeks, and those sessions were about 2 hours each. So nothing like that amount of training. We did have a manual, but they didn't do therapy in the traditional sense because we didn't have funding to pay them, for example. So these people, they used it in their everyday work. So they use it. Some of them are religious people or they're community leaders. Okay. So that's an example of task sharing. All right. These are some of the ways that it's delivered. So these are the kind of interventions that are delivered in this approach. So you can see a lot of it's CBT based. Okay, and there's also non-specific elements there. All right, I'll just skip that slide. Okay. So I'm going to go now to our approach, which is slightly different to the others. Okay, so we are training healthcare staff, but we're not training healthcare staff to deliver therapy in the traditional sense. What we're doing is training healthcare staff to increase the efficacy of what they're doing in their normal appointments. So we don't have more healthcare staff. They don't have more time. What we want them to do is to deliver some form of intervention, really, really, really brief interventions in their normal appointments without increasing the time they spend with patients. So it's kind of making the best of what we have already, rather than trying to add more resources, because everybody who works in these settings knows that it's really hard to do that. You kind of, you don't have a lot of power. You can't just say, I want some more staff here and there, because that normally isn't going to happen. Okay, and you just end up bashing your head against the brick wall. So what we're trying to do here is increase the efficacy of what we have already. Right, so I'm just going to talk a bit about how we develop this and how we turn this into an ACT intervention. So as I said, this started about 10 years ago. I was doing my PhD, I was doing it on collaborative practice. So we had our healthcare system, it was fairly fragmented. Lots of people working in silos, and often the patient and the healthcare providers are not forming a collaborative relationship. Okay, it was the healthcare provider saying to the patient, this is what you do. And the patient's often saying, yes, doctor, yes, doctor. Okay, the healthcare provider saying, take this medication. They're like, yes, yes. And then often they don't do it because they're not making the decision together in the first place. So we were trying to change this. We're trying to get people working together better. The healthcare providers working better with patients, healthcare providers working better with each other. Okay. And in this system, there wasn't any written care planning. So we were trying to introduce that. We were trying to introduce written care plans. So we brought on board these notebook things. Okay. And we were trying to get people planning together. So this is an example here. I wonder if I can zoom this slide. I can, yes. Okay. So this is like a staying well plan. We're getting people to make plans together about what's going to make them better. Okay. And this is a patient will be doing that together with their healthcare provider. Right, and each of these, we provided these little notebooks. Actually, I made most of these, and they put these pages in, okay, as a way of adding to their care plan each time. Because one of the problems as well in this setting is that people often see a different healthcare provider on every appointment. So, you're sort of being able to communicate with the next healthcare provider what they're actually doing therapeutically is quite hard. And if you don't do that, what happens is people get the same therapeutic intervention every single time they come. And that therapeutic intervention is normally don't forget to take your medication. So they'll just be told that. And that's the only form of therapy they're getting. It's don't forget to take your medication. Or there might be it might be sometimes like health lifestyle advice. Okay, but it's often one session doesn't follow from the next because it's different people providing it. And the other problem is in this setting that most people are not trained in any form of psychological intervention. In fact, they're not trained in mental health. So the majority of people who are seeing patients, they're medical officers. They'll be seeing patients in the outpatient clinic. They'll normally be seeing around 20 patients in a morning. So they have about 10 minutes per patient. Okay, and so what you can do is fairly limited, right? So we're trying to increase collaboration, okay, by using this kind of thing in doing this form of like written care planning. Okay. So this is some of the things we're trying to increase when we started this week, because we know that in therapy there's a few things which are kind of universal, that if you can deliver these things, people get better. All right, we've known this for quite a long time, and this is these are what we call the common elements. Okay, these common elements are the things that have the biggest effect size. Okay, so collaboration, that's the thing I was targeting to start with, has a really big effect size. Right, so all of those things, all of these common elements, these are all common elements. Those are the highest. That's what has the biggest effect size. Okay, so when you look at the things like adherence to protocol, this is like differences between treatments, it's quite low actually. Right, so the most important thing is we get the common elements in, and that's what we're targeting in this trial, in this study to start with. Okay, so the problem was, if we want to teach people collaborative practice skills alone, it doesn't really work because people don't come to training on that kind of thing. So they feel like, I know this already, so why do I want to come? And it's just really hard to get these messages across. What they actually want to know is, how do I help people? So, you know, you've got somebody sitting in the house for 5 years, not leaving the house, you're giving them all the medication you can think of, they're still not getting better. And they're like, what do I do next? And the patient's the same. Their main thing is, what do I do? How do I fix this? That's what matters to them. So they want something active. They want to know, what do I do? What do I tell the patients? We also know that active treatment, that active methods, they perform better in trials. So if we look at a meta-analysis, sorry, I haven't got the reference here, there's meta-analyses looking at this, and when you look at things like activity planning, it does a lot better than non-directive methods. So we know active methods work better, and that seems to be what people want. That's what they want to train in. That's what patients want to know. If you don't offer anything active, it's also quite hard to form an alliance because they feel like all you've got is medication and validation. What else are you offering me? So we wanted something active in there. Now, that's where we started using this. We started using ACT. Part of the reason why we started using it is because I was training in it at the time, but it was also because it's really, really good for LAMIC settings, which I think is why a lot of you are here, because it works in these settings. Now, why is it so effective in these settings? I think a lot of it's about the flexibility. So what that means is very brief interventions, they're possible. We don't have to use that traditional therapy model where you see a patient for an hour each time for 10 weeks. We can play around with that. Okay, that's what the focused acceptance and commitment therapy approach does really well. And that was part of that approach was part of what influenced us as well. Okay, so the flexibility is not just in the delivery of therapy, it's also in the training. Okay, so it can be very brief or it can be really in-depth. People can train for years in it, people can train for an hour in it, and you benefit from it, whatever the length. So I've done hour-long trainings, and I think it does change stuff. It makes a difference. And I think the concepts are really accessible to non-specialists, especially like the triflex model, the stuff Russ Harris has developed. I think he's been really, I think he's one of the biggest influences in LAMIC settings, just because his videos are all online. He's a really good communicator, and he's developed these models which lots and lots of people can understand. So So that kind of thing, it makes it really accessible. The next thing is trends diagnostic, and it can be used for a huge variety of problems. And I think what matters in this setting most of all is you can use it for physical health problems. Lots of people present with physical health problems, and it can also be used for psychosis. And as I've said before, psychosis is probably one of the psychotic illnesses, probably more common in psychiatric settings than other types of illness. Okay, and there's good trials on this, good randomized controlled trials, as Merve said earlier in her talk about Turkey. Okay, there's also few barriers to practice. Okay, so we don't have things like certification getting in the way. We don't have to have, you know, so many sessions of peer supervision in order to practice. We can just go off and do it, and that means we can have organic growth, and that makes a big difference. And then the ACBS community itself, we've got an open community, we've got freely available shared materials, lots of avenues for support, and we have peer supervision groups, which means we don't have to have the expense of paying for some external supervisor, which is what you have in CBT, for example. And that's one of the barriers for that expanding. So these are some of the reasons why this approach is really good, and what's one of the reasons why we chose this to be the active part of our interventions. So I'll just talk briefly about the course. I'm not going to go in too much depth. We started in around 2018. To start with, it kind of started off with the hospital continuous professional development. We're trying to do it there. It's really hard doing things in continuous professional development time with doctors, because their phones keep going off and they have to go off to the ward to see some patient or whatever. So we decided we need to bring them out of the hospital to do this. So we took them, so we did the course outside of the hospital. The medical officers, they could only release very few at a time. So then we widened the course out to the district medical officers and the primary care medical officers. They attended as well. And we realized that they were really benefiting also. So it wasn't just the psychiatric medical officers benefiting, it was much wider than that. We also did a half-day format for mainly for the ward staff. Again, a lot of difficulties releasing them. And when I talked to the matron, they said, okay, we can have half a day. So we did it in half a day. And we did a lot of stuff on values to help them manage. It just kind of helped them to humanize the patients and to manage some of the difficult behaviors they were seeing. Okay, so the course, we're not trying to replace therapists. Well, there isn't a lot of therapists to replace in the first place, but what we're trying to do is just improve outcomes a bit for the majority of patients. So as I've said before, it's public health approach, improve things a bit for lots of people. That's what we're trying to do. Okay. So we're running the course mainly experientially. We're using a lot of social constructivist methods. What that means is we're taking the participants' own experience. We start off with a focus group, and we're using those experiences, and we're getting them to kind of integrate with the new material. So it's a lot of kind of backwards and forwards conversation. We also have an online component. So we developed an online course, which they do first, and then they come to the course, and that's mainly focused on practicing skills. So it's not a lot of talks, it's skills, and we're practicing. So very similar to the way you play piano, learn to play piano or play tennis. You can't learn it by listening to people, you have to do it. Right, so it's those skills I showed earlier. That's some of the stuff we're focusing on. This one, I just mentioned, we have to teach people how to give feedback first, because we do a lot of small group work, and we need to make sure that is functional, that it works properly. So we teach them how to give feedback in a way that helps people learn. Okay, and quite a lot about environmental safety to start with before they do the skills training. Okay, and then more specific skills, and you can see quite a lot of ACT-based skills here: goal setting, values, mindfulness, anchoring, grounding. We give them the triflex model and talk about experiential avoidance. And I think that's really helpful for medical officers, because often they can feed into experiential avoidance. For example, encouraging people to take a lot of time off when they want to avoid. So it's so giving that model, I think, is really helpful. And you can do that quite quickly and help people understand that quite quickly. Okay, then care planning we're doing, and what we do, these are more complex skills, the care planning and the relapse signature and relapse drill. So we're using all the ACT skills to feed into this. So each session kind of builds on the next one, starting off with the not simple skills, the kind of collaborative skills and the more kind of MI based skills, and then moving on to the ACT skills once they've developed that, and they keep practicing the collaborative skills as we're doing this. And then when they're doing this, they're also practicing goal setting and practicing values. So it's kind of layered. Right, so we have evaluated. It's not really feasibility now. It's kind of we're kind of piloting, and I'll show you where we are. Right, this is the Kirkpatrick model, which people who do educational research are probably fairly familiar with. When you're evaluating any kind of educational intervention, you can do it at any level of like this. So to start with, you can think, how do they feel about the course? What did they learn what they're supposed to learn? Okay, so that's normally your end of course feedback. That'll be your assessment. Okay, then this is where we're assessing did it change behavior in the real world? So when those medical officers go into the clinic, are they actually doing something different? Right, so that's what we evaluated at. That's what we've done so far. The last level, did it improve things for patients? We haven't done yet. As I say, what we're expecting with this kind of approach is is fairly small effect sizes, but affecting a lot of people. So that would need quite a huge trial. So we haven't done that. Okay, that would need a lot of funding. So we're here right now. Did it change behavior in the real world? Okay, so we studied this. It was about a year ago. No, it's just before I came to England. So it's about April last year. We developed this checklist. So one of the things that sometimes gets in the way, I think, of research is not having stuff operationalized well. So we had to develop a checklist to start with, because we needed to know what's happening in clinics to start with. Okay, so if we want to know, are these medical officers changing their behavior in clinics, we need to see what's happening to start with and see what they're actually doing. So we developed a checklist. Okay, we got some research assistants to observe some consultations. Okay, so we recruited, I think, I've forgotten how many, I think it was 18 medical officers, and each of those, the research assistants, they observed between 5 and 10 consultations for each of them. Okay, then we did the course, and then we went back and observed again. So that was the basic layout of the research. Okay. So we created this checklist. This is a list of skills, okay, which are in some ways taught on the course. Okay, so you can see I have put them in groups. That's not any form of factor analysis. This is just for convenience. We have done factor analysis, but I won't discuss that today, but it does roughly follow this. Okay, so we've got, are they gathering information in a therapeutic way? And these ones here are quite ACT-based, asking specifically about emotions and about thoughts. Okay, some of these are just general skills which you would expect somebody who's working collaboratively with a patient to be doing. Okay, we've got shared problem solving, shared decision making. We've got planning, okay, and then specific interventions. So we have this kind of informal mindfulness, so teaching mindfulness in everyday activities, things like washing your hands or walking and that kind of thing. Okay, acceptance of emotions, anchoring and grounding, self-care kind of stuff. This one isn't actually very ACT-based. It's almost the opposite of ACT, teaching ways of temporarily reducing strong emotions. So that's more like the DBT approach, some of the distress tolerance skills, activity scheduling, and specifically asking the patient, can you practice this between sessions, and getting them to increase motivation to do that. Okay, and we operationalize something like this. Okay, so we developed this list of skills. We took it to our team in our university department. We also sent it to other people outside of our team. I think Eugene was one of them, and asked their opinions. Okay, and then we tried to use this thing by watching videos of consultations. We all sat together, watched the videos, and thought about where do we where did we differ in terms of our opinions? And if the item wasn't clear, we made it more clear. So we added the stuff in red was what we added afterwards. So we did this with every item, okay? And we developed like a list of operationalized skills, okay? And then we validated it again by watching videos of consultations, okay? Most of these we found online. They're videos of primary care consultations mainly. Some of them are focused acceptance and commitment videos. Some of them are motivational interviewing, mostly based in primary care, okay? And we got 8 expert raters. We asked them to rate 30. They missed some, so 5 of them rated at least 27. Okay, so these are the inter-rater reliability for the individual items. Okay, some of them are really high, like the mindfulness-based ones seem to be quite high. So those are ones which seem to be quite easy to identify and get it right. Some of them are quite a lot lower. Okay, the individual ones for each individual item doesn't matter as much as what it is for the whole scale, because we're not just going to rate the doctors on just one item. We're going to rate the whole scale. So we use something called generalizability theory. So we have a G coefficient of 0.84, which is a G coefficient. It's kind of a cross between the inter-rater reliability and Cronbach's alpha. So it's pretty good. It's pretty decent generalizability. So we've got a fairly reliable scale. That's what I'm saying. Okay. And this is our results. So before and after. This is before the course. Okay, the observations before the course. And this is after the course. Okay, and this is the length of appointment. So this is minutes. All right. Most appointments were in this category. So it's kind of divided into thirds. So this is 4 to 6 minutes. This is 6 to 7 minutes. And this is 7 to 18 minutes. So you can see whatever the length of appointment, there is an improvement. Okay. And just a little bit about the statistics. So we use mixed model analysis using R. Okay. We developed, we tested various models. Okay. With this approach, with mixed model analysis, what you do is you develop a model, okay, and you test it and you see whether other models with more stuff in gives you a better fit. So that's the way you do it. Okay. And we found that the best fit is where we allow each doctor in this to have a different slope. Okay, so you see these faint lines here. These are the different doctors, and you can only see 3 here, but actually there's about 18. It would just look a mess if I put 18 on them. But you can see each doctor has a slightly different slope. So some have a huge increase in the number of skills used, and some a little bit less. Okay, so that's what the model allows. All right, and if we include length of appointments, the fit increased. Okay, if we included mental health problems in there, it didn't increase that much. So in fact, it didn't increase significantly at all. So including mental health problems in the model didn't seem to matter. Okay, so most of these appointments, they were general health appointments. They were things like they're coming to see the doctor because they have high blood pressure. Okay, so these are general health appointments, and we're seeing an increase in the skills used. Okay, so doing the course increased the number of skills per appointment by close to 4. So they're using 4 extra skills per appointment compared to before the course. Okay, if we increase the length of appointment, it also increases the number of skills, but only by 0.25 per minute of appointment. So we'd have to increase the length of appointment by quite a long way to have the same effect as the course. So what it's showing basically is the course is increasing skills use among the medical officers. It's working at that behavioural level. So it is changing the behaviour of the medical officers before and after, right? It doesn't tell us anything about whether it works for patients. That's another level. That's another study, but it's working in terms of the behaviour of the medical officers. Okay, the stuff at the bottom is just showing that it's meeting the assumptions of the model. Okay, if you like p-values, it's significant. So we see a significant increase. Right, so that's roughly what we did in terms of, or that's some of the approaches we've used in SABA. Okay, now I just want to think a little bit about the future. So as you can see, one of the things we did was to try and operationalize what's happening in appointments. And I think that's really important. It's because if we want to improve things, if we want to make things more efficient and more efficacious, we need to know what's happening, and we need to be able to measure stuff properly. So I think we need to do more of this. I think we need to be doing more operationalizing, and our scale, it only had on the stuff that we were teaching, but I think there's a lot more skills that could potentially be on there. And if we can measure that properly, it would kind of be a way forward. And one of the reasons why we need to do that is because we need to know what helps. So in your average healthcare appointment, the healthcare provider will be delivering interventions of one form or another. They might be delivering a little bit of advice, or for example, the way they say things, and those things, they could be harmful, they could be helpful. So we don't know at the moment what's helpful and what's harmful very much. Okay, we have some idea from communication skills research, but when it comes to the kind of more specific therapeutic skills, we don't know very much. Right, so as I said before, I'm quite influenced by the public health approach, and I feel that if we genuinely want to improve the mental health of whole populations, we need to use that approach, because if we're trying to deliver to just a small number of people, it's not going to be as effective as delivering to lots of people. Okay, so all of these kind of task shifting methods, they kind of do that. Well, like, for example, you look at the Self-Help Plus program, that's what that does as well. It's trying to get these interventions to as many people as possible. Okay, we need larger trials, because if we're doing these kind of things, we're expecting slightly smaller effect sizes, so we're going to need bigger trials, and that's obviously going to need funding. Okay, now the future, I think we're going to see a different type of research, and Steve Hayes this morning, he talked about idionomic research. I feel that's really important for our settings, because we need to know specifically what works, not just whole therapies. So at the moment, the approach tends to be you produce a manual for a specific disorder, and you take that to a randomized control trial, and from that you find out, does it work or not? Okay, the problem is, in many settings, you can't deliver whole therapies, and you can't train people specifically for only one disease or only one type of symptom. Okay, which is what a lot of the CBT approaches they'll do. So they'll train people, for example, to deliver therapy only to people with, or maybe to one type of group of people, like to young people with depressive symptoms. Okay, and you'll have to go on a 2-week training program to learn how to do that. And it's not practical in the real world setting. So it's, so if we can find out specifically what are the ingredients, what do we actually need in there? It's like you're getting to the essence of it. You're trying to extract the smallest element from what you're doing and trying to find what is it that makes it work. Okay, and I think the idionomic method that will do that. There's these things as well called micro-randomized control trials, which I was quite excited to read about. So these are done to see whether individual interventions are effective or not. I'll just put this up. So let's say you're seeing a client, okay, you find they're emotionally overwhelmed due to voices, okay, which is something that people in primary care settings in Sabah, they would come across this quite a lot. A lot of the patients will be feeling this. So what do? They're emotionally overwhelmed due to voices. I've already increased the medication. What do I do next? Okay. So you could either teach grounding, you could teach a distraction method. So what we do is randomize at this point here, okay? And I think it involves devices. Obviously, it involves some sort of mobile device to be able to do the randomization. So you randomize here, okay? And then you look at the outcome. So you look at the outcomes very, very soon after when you've done the intervention. So you could randomize here, okay? Let's say you get the medical officer to press the button to randomize, and it says teach grounding, okay? And then the person has their own mobile phone and they're measuring outcomes on their phone, okay? Which is very similar to what Stephen Hayes was talking about this morning with his app for idionomic research, Okay, so so you have quite a number of randomization points. As you're seeing one individual, you keep randomizing them at each decision point. Okay, and then from that you collect an awful lot of data, and you'll be using methods probably similar to what I described earlier. So the mixed method, kind of the mixed model kind of statistics, and you can find out which individual intervention works at which particular time for which particular type of patient. And that's the kind of information we need if we want to increase the efficacy of our appointment. Okay, so I spent quite a lot of my life teaching. 15 years I spent as a lecturer teaching medical students, nursing students, okay? And one of the things we did is introduce this kind of training into the curriculum. It's actually an awful lot easier than trying to train people who are already in post, because as I said, if they're already in post, they have to be released from post before they can come to any training. So so what we've been doing is trying to incorporate it into the curriculum, okay? And the aim is similar. Oh, I've lost my. We're trying to increase this therapeutic effectiveness. By the point of graduation, they're therapeutically effective. That's what we're trying to aim for. Okay, so in our university, I'm just going to say how we incorporate things. So we didn't actually officially change the curriculum. We already had lecture blocks. We already had slots. What we did is just change the content of the lectures. So we had a lot of stuff, for example, on Freud. Like when I first arrived 15 years ago, we had a lot of stuff on psychodynamic theories and all of that kind of stuff. And it wasn't particularly useful for people in the real world. So they might know, for example, what countertransference is and transference and what an id is, but they were just using it as kind of a language. It was like, you know, when people, they use psychobabble and they, so it never really affects the patient. It's not really working. So we just changed that stuff. And this is how we fit it into the curriculum. So for example, in year 1, we do a course on communication skills. So that's those basic skills I was talking about, those collaborative skills. Okay, not so much the specific therapy skills, but the collaborative skills. Okay. We have a lecture on self-care. That's where we introduce the ACT model. So just 1 hour and we go through the triflex model and we'll be talking about how they can use it for themselves. Okay, in year 2, we have a neuroscience module. So we'll be introducing the brain's response to trauma, the flight, fight, freeze response. We introduce the concept of experiential avoidance when we're talking about depression and anxiety. Okay, we have a module called Introduction to Clinical Skills. We'll be getting people to think about the patient's perspective. So we're trying to introduce compassion and those kind of models. And we do also do some more self-care based on ACT. Okay. We then have the psychiatry module. So in that module, we do a lot of role playing, and a lot of that is very similar to the ultra brief intervention course. So we're introducing how to do care planning, how to do goal setting, and some of the stuff around acceptance we're doing there. Okay, at the end we examine, because everybody who teaches medical students, you kind of know that they don't tend to focus on stuff that isn't examined. So put it in an USCI exam. They know this stuff's going to come up, and what that means is they keep practicing with their friends over and over again all of these skills they've learned. Okay, so that's sort of how we're introducing it, and I hope what we're doing is graduating people who are reasonably therapeutically effective. Right. So in summary then, so there are lots of ways of delivering these kind of interventions. You need to be flexible, need to be creative. And what I found, and I think what a lot of people are finding, because a lot of people are using this, is the contextual behavioral science approach. It works really well because it allows you to act in these ways. Okay, so I'm going to finish there and I'll see if anyone's got any questions.
Nope, doesn't seem like we have any questions. All right, I think we require Dave and Dee here for this session.
Okay. Okay then. And
Thank you very much for talking
yeah,
about.
thank you.
Not a
Uh,
question, but just a comment. I think it's a very useful model for all the countries to empower, and I think it brings a lot of benefits for patients, like not having just a normal session, but benefiting from a bit more therapeutic input.
Thank you. Yeah. Yeah, I hope so. I think we can use it. Daniela is, I know from here, she's my consultant in CAMS. So I think we can probably do some of this here as well. And originally from Romania, aren't you? So,
Yes,
do you think it would work there as well?
I think so. Yeah, we had to be creative there to
Yes.
bring all the resources together. And I
Yeah.
think if you don't ask for more stuff, if you don't ask for more money, but bring more benefits for the patients, I think it's ideal.
Yes. Yeah. Thank you.
I think Erica has a question. Go ahead, Erica.
Do we have time for one quick question?
Yeah.
Thank you, Dr. Wendy, for that presentation. Perhaps just a methodological question that I have. Do you have a specific criteria to who can join this intervention course? Is there, even though it's for non-specialist healthcare, but do you also discriminate the criteria or requirements, like a minimum requirement to actually attend this course?
No, we didn't. In terms of that, the study we did, we were aiming at primary care medical officers. So we're aiming at primary care and district hospital as well, who have no training in mental health. So that's who we were aiming at. But in terms of when we're delivering the course, we didn't have any requirements. They were just people who were patient facing, mostly the people who have some sort of contact with patients. Eugene was on the course. He was one of the first people. I think you came on our second course, didn't you?
Second.
Yeah, it was just after you finished, wasn't it? Many years ago.
The first course would be the nurses, and then the second would be us.
Yeah. Yes.
Okay.
So it was back in 2018, 2019. Was that when you just after you'd finished, wasn't it?
2019.
2019, yeah.
Yeah.
Yes.
Yeah, because I can imagine, like, depending on perhaps the number of the number of years of experience, someone would have like a perhaps an officer compared to like a nurse. They would have different ways of approaching, using and applying the course that's being taught to them, and that could also affect like the number of skills that they use in their clinical work. So I was just wondering if there is like a discriminant between like the groups of non-specialist healthcare professionals that you teach, and how do we compare the number of skills that they apply in their clinical their day-to-day clinical activities.
Okay, in terms of that study we did, the only group we're focusing on is primary care medical officers and district hospitals, and they had a fairly similar amount of experience. So I think I don't think we'd have seen anything statistically. I think we collected data on it, so I can look at that. I can see whether that did have an effect. But my suspicion is it won't, because I think they were all fairly similar. They're all people like in their 20s mainly, who've graduated in the last 5 years. So I think probably not that different. We didn't for that study, we didn't look at the nursing group. We've done that qualitatively. So qualitatively, it does seem to be working. What they're saying is that it helps us to see the patient as a full person, because when you run on a ward on that kind of ward, it's like all the patients sometimes feel the same, and all you're seeing about them is their illness, and you don't see the rest of them. So what they said was that, especially the value stuff, it really helped them to see the full picture of who they were and help them to think about them as individuals rather than just as their illness. So that's what we found with the nursing group qualitatively.
perhaps it's like a separate conversation that we can have, because I'm really interested in what you're doing and the work that you have done in Sabah before you left. But just also, you mentioned just now, like, what you find that was really promising in applying this approach is for the lay people. And perhaps, in a different conversation that we can have is how do you adapt it to a lay person compared to those to the non-specialist MOs that you have trained. Like, what do we define as lay people? Like, educators, perhaps, teachers. Like, so how can we adapt what you have taught to the MOs to this group of lay people who would
Yeah, we
perhaps
did that.
apply it in schools? Yeah.
Yeah, I mean, my friend Nicholas Patton, he's been doing a lot of this kind of stuff in schools. We've been we taught it to church groups, so like the pastors and so on. We taught it to village leaders and the the village committee people. I even did it with prison officers at one point. We started a course there, but we had to end that because of the pandemic. So we have adapted it, and I think because the materials we use are fairly simple, so we had like each of our skills has only one page about this big, so it has hardly anything to read, and we deliberately designed it like that, so sort of like a recipe book, so that people don't
simple,
even...
comprehensible.
Yes, that's the idea. Yeah, and that recipe book, I think it's been passed around quite a lot, hasn't it? So so a lot of people have seen that at some point, even if they've not officially come on the course.
Thank you, Dr. Wendy. Thank you so much for that.
All right, thank you very much. I think we have to stop here because our next session is about to begin.
Yeah.
Wendy, could you pass me the host status?
Yeah, okay. Send it over. I have to stop sharing first.